So today's guest speaker is
Sorry, if you could switch your video off, the bandwidth will increase and then we will be able to hear you properly. You can close your video. Yeah, there must be some bandwidth issue. Must be.
Shivani, you can start.
So I would like to I welcome Dr. Smita Atwale ma'am, who has completed her BDS and MDS in prosthodontics from Nayar Dental College, Mumbai. She has 22 years of experience as professor, PG guide, and PhD teacher in DY Patil Dental College, Pune. She has a private practice restricted to prosthodontics and dentofacial rehabilitation, Pune. She is a consultant maxillofacial prosthodontics, geriatric dentist, and founder member of Cleft Care Center in Dinanath Mangeshkar Hospital and Research Center, Pune. She is member of editorial board, JIPS. She is a founder and EC member of IPS Pune branch. She is former joint secretary of Geriatric Society of India, Pune chapter. She is a member of Geriatric Board Federation of Special Care Dentistry. She is a member of IDA, IPS, GSI, ISOI, FSCD, and ISCRP. She has completed a certification course in geriatric medicine conducted by Geriatric Society of India journals and has been a guest and keynote speaker at national and international conferences. So I welcome you, ma'am, on the behalf of MIDSR Dental College. And we are having Mr. Bhushan Bangar, sir, who is the moderator of this session.
Thank you so much, Dr. Shivani. Dr. Smita ma'am, you can start your screen and share
Yes.
it. And
yeah. There is a message flashing that host disabled participant screen sharing. So if the host allows me or makes me co-host, then I can share my screen.
Just give us 2 minutes, ma'am.
Yeah, sure. Take your time. No problem. Can everyone see the screen now? Dr. Bhushan, Dr.
Yes, ma'am.
Vaishnavi, you can
Yes, ma'am.
see? Okay.
Yes,
If
I
there
can
is
see.
any problem, please let me know. Okay.
Sure. Yeah.
Because if there is any bandwidth issue, I will immediately close my video so that the presentation is clearer. Okay. So I'll
Okay.
just begin. A very good morning. And we were just discussing before this session that online lectures are more challenging than actual lectures or offline lectures. Because as Dr. Ishita pointed out, we cannot have the eye contact with you people when you are attending the lecture. And also that these technological glitches, like we are all in our 50s, so we are except Ishita, of course. So we are still getting used to the technology, and every day there is a new challenge, but still we go on with it and we embark on this journey of geriatric dentistry. So namaskar all of you all from Pune, land of Ganeshotsav, and with the blessing of Lord Ganesha, let's begin our presentation. So this is something about me, which Dr. Vaishnavi has already said. So this was a hoarding which my friend from Kochi, Dr. George John, he clicked a picture one day and he sent it across to me. He said, Smita, can you believe there are such hoardings which have come up in Kochi? Talking about senior homes, assisted homes, or old homes and all that. This is so new to all of us. Yes, indeed, it's very new, and that gives us a realization that world is graying, and even India is no exception. In Pune also, we are having these kinds of hoardings everywhere, advertisements everywhere. That shows that there is a rise in the elderly population and their needs. So currently 10% of our population is more than 60, and by 2050 we expect that it will be 22%. So imagine all the young prosthodontists or all the postgraduates from various departments, not only them, the general dentists, dental professionals, when the generation next goes to their practice, there will be more and more number of geriatric patients. And still we are at a loss, still we don't know how to handle the geriatric patients differently. So, till we have some formal courses or something like that, let's not stop. Let's not stop ourselves from gaining a practical know-how of handling a geriatric patient. So, just the scope of geriatric dentistry, I would like to say that it is specialty in dentistry that involves multidisciplinary approach in evaluation of oral health, diagnosis, prevention, treatment planning for senior citizens. In India, we call it 60 years and above. That's what we say, senior citizens. In different countries, it could be different. Like in US, it is 65 and above. In Japan, it is 78 and above. So our criteria, let's stick to our criteria, 60 years and above. We aim at dental treatment for elderly and or medically compromised patients. This thing is going to come more and more in my talk that, as the age advances, the number of systemic disorders that are present commonly, like diabetes, hypertension, some cardiac issues, you will see very commonly that the elderly people are already having one or more than one such disorders. Then, providing palliative treatment and symptomatic relief from health problems like mucositis, xerostomia, dental caries, and chronic periodontal problems. See, when you are managing geriatric patients, you will get to know when you practice that, there are so many limitations. It's exactly like pediatric dentistry. There are so many limitations managing a geriatric patient on the chair. So every time you may not be able to give a perfectly textbook like an ideal treatment for the patient, but at least if I can relieve the patient of his or her pain, at least I can make him or her comfortable. I think my treatment, even if limited success, it is a great success because it makes change in the daily life of that particular patient, makes the patient comfortable. Now let's come to the definition. We are all very fond of definitions, and your generation is Google generation. So if you scroll, you will get 10,000 definitions of geriatric dentistry, I think. But this one definition is all encompassing definition. So I like it. Geriatric dentistry or gerodontics is the delivery of dental. I have added my word here, orofacial care to the older adults, involving the diagnosis, prevention, and treatment of problems associated with normal aging and age-related diseases. Okay, so there are some problems, dental problems, which are prominently seen, like gingival recession, which comes with age, and there are some age-related diseases. So geriatric dentistry takes care of both. And the third and the last part of the definition, which is very, very important, and I will say this word at least 10 more times during my presentation, as a part of an interdisciplinary team with other healthcare professionals. As specialists in every field, we tend to, make a tunnel vision. We just think of our own specialty. We restrict ourselves to our own knowledge. And, somehow, I will not exactly call it ego issue, but we do not interact with other specialties. The geriatric patient is going to be looked after by many people. It's not just the dentist, it's going to be the physician, it's going to be the physiotherapist, it's going to be the caregiver, it's going to be the nursing staff. So many specialities are involved. So we all have to come together and we have to see that we give a complete treatment, what we call these days a very, what to say, sought term, holistic health. We have to provide holistic health to the patient. So this is, according to me, an ideal definition of geriatric dentistry. So look at that traffic police. I always consider dentists as traffic police. And when I say that, I think the role of traffic police is extremely important. In Pune, in Mumbai, in all big cities, we are facing this problem day in and day out. And, imagining that chaos at the traffic signals or overall on the roads, it is really so important to have somebody to guide the traffic and, make our lives comfortable. So let us see how we are, somehow similar to traffic police when geriatric dentistry or geriatric health is concerned. Geriatric patients come to us or they are referred to us. I am a hospital consultant also. So some patients are referred to me for removal, restoration, and replacement of teeth. We diagnose the existing orodental problem and guide the patient for complete oral rehabilitation. The term, again, a term which is gaining a lot of importance in dentistry, full mouth rehabilitation or complete oral rehabilitation. We identify the oral manifestation of systemic disorders. Please go back to your oral pathology. Please go back to your OMDR. Please go back to your third year medicine and surgery. And you will realize that so many times it is our responsibility as dentists to diagnose the oral manifestation of systemic disorders and accordingly guide the patient for further treatment. So there are various issues. I will not go in detail because I have to restrict my talk to 30 minutes to give you an introduction, an overview. But these are some important things which all of us should think. No branch of dentistry is separate from the other branch. We are not, separated out from community dentistry. It's so important to think about socio-economic issues, the financial problem, the disabilities of the geriatric patients, the medical and health issues like various diseases, systemic disorders, behavior of the patient because of the age, because of, again, some psychological, emotional problems, and oral health related issues. So nothing is separate. It's all interlinked and we have to think of all these problems. Some socio-economic problems. You will see this horrifying picture and this is real. This is a patient which reported to me in my Dinanath Mangeshkar Hospital OPD. There was all this degenerated tissue below this removable partial denture that was stuck in the patient's mouth with rapid repair or, self-cure acrylic material. Patient was having excruciating pain. And I asked the patient, where did you take the treatment? So he admitted that, somewhere some quack gave him that treatment. And I asked the reason, why didn't you go to the dentist properly? So he said, Madam, it was not affordable for me, but I had to have the replacement because it was looking bad. So I chose this option, which was a cheaper option. This is a stark reality in our country. Older individuals in low socioeconomic strata, where there are challenges for the primary caregiver of the dependent, disabled, vulnerable relatives. The primary caregiver also has to take care of his or her children who are growing up, their school needs, their health needs of the family. Automatically, the senior citizen's health and especially dental health takes a backseat because of the economic reasons. Of course, there is exponential growth in the cost of the per capita cost of the healthcare in general and dental care in particular. So again, oral healthcare takes a backseat. And those individuals who are totally dependent on the social or government healthcare system, well, the problem is population. We have too many patients to deliver care to, and too less hands, too less hospitals, too less facilities. So these are all the problems which one should keep in mind and then look at your geriatric patients' well-being. So medical and health issues, I will not go in detail again, as I said, but public health problems, existing diseases, at least one chronic health problem, which I already stated, and most important thing, the last line, diagnosed, undiagnosed, and misdiagnosed health problem. Over here, our role is very, very important. We should not miss anything. We should pay attention to everything. Now, we all are very fond of classifications also. There is an entire article dedicated to the categorization or classification of elderly population. But I like this classification the best as a prosthodontist maybe, or this is more practically oriented, Ettinger and Lyon et al. Functionally independent elderly. These are the 70% of the elderly population who are able to go to their dentist themselves. Frail elderly, they are the 14% patients who have some chronic condition, maybe arthritis, maybe cardiac issues, maybe fluctuating BP, or some such problem because of which their mobility is impaired. But still, with somebody's help, they can reach the dental clinic. But functionally dependent elderly, this is approximately 5% of the entire geriatric population. They are homebound. They cannot leave their house. Some people are bedridden. Some people are institutionalized. They are in some old home or some elderly institution from where they cannot report to you for dental treatment. So this is our functionally independent elderly. Hale and hearty, I will not say that because she's having diabetes, she's taking treatment for hypertension, but she is able to go about, she is able to come to my clinic, and she is comfortable in her life, even though on the support of medication. Frail or functional dependent elderly. In city of Pune, we call it the city with maximum number of parents of NRI people. The husband, wife, they are there in India. Their children are abroad. Sometimes uncle is living alone, auntie is living alone because they are more comfortable living here because of their social life or whatever things that are comfortable for them here. But the problem is who will accompany them? Like you can see this lady who has come to my OPD. She is having severe osteoarthritis. She is debilitated because of arthritis. She's wheelchair bound. Her husband accompanies her all the time, but uncle has already undergone bypass surgery approximately 6 months ago. So who accompanies whom? Who will accompany them? That's a big problem. And in COVID time, we, face these patients a lot. We have lived through horror times and patients could not come to us. Patients had problem. Our phone kept on ringing, doctor, what to do? We have these issues. Mind you, we went to patients' houses. We attended whatever problems we could attend at home. I'm absolutely not claiming that you can do everything for the homebound patient, but simple things. For example, in prosthodontics, you have to relieve a denture, you have to make a duplicate denture, or you have to make a denture if there is proper assistance. You can also make a denture for the patient, or you can diagnose a problem. You can prescribe something to the patient. Okay, all these small things can be done. There are some things which can't be done, but these things we did. We went to the patient if the patient could not come to us. So I will scare you with a big list now. Just look at this list. I'm not even going to read because it will take a lot of time. But these are the problems which your elderly individual may be facing. The patient who comes to you may be facing these problems, and that's where history taking and probing questions are extremely important. The list is not over. Take a look at this. Parkinsonism disease is taking its toll. Osteoporosis, which is there because of increase in the age and decrease in the bone density, and recurrent falls, they are the deadliest because patient can have multiple fractures, immobility, dementia. And these, what are called as giants of geriatric medicine, these are some disorders which are multiple pathologies. One patient is taking many medicines. One medicine for diabetes, one for hypertension, one for cardiac problem, one for cholesterol, one for thyroid, multiple pathologies. Atypical presentation of disease. Again, brush up your OMDR and oral pathology skills. There could be, the symptoms could be something else, that the patient is feeling dull, the patient is feeling weak, and the doctor takes a chest x-ray and the patient is already in the second stage of pneumonia. So atypical presentation of diseases. Immobility. Again, as I said, homebound patients, for some reason or the other, the patient cannot move. Instability falls are extremely common. There are some things which you have to take care in your clinic, your hospital OPD, where you have to take care that the patient does not stumble and fall, because elderly people are very prone to fall. Incontinence. We do not have the concept of diapers in our country yet, commonly, but there is another issue to this. There are patients who cannot afford diapers. So incontinence is another problem. Intellectual impairment, like, forgetfulness, confusion, or patient is unable to understand, unable to comprehend. Late presentation of disease. The disease is already there. An accidental blood test just reveals some disease, but the presentations are not there. Sometimes silent presentation of disease. The disease is already present, but there are no signs and symptoms. Very common in elderly. And last but not least, the deadliest one, the polypharmacy. Patient is already having so many medications. Patient does not tell you and you do not ask. Both parties to be blamed. And you prescribe something which causes a severe drug interaction. Always be open for dialogue. Call the patient's primary caregiver, ask for all the prescriptions, and in case of doubt, please do not hesitate to contact the patient's physician. So polypharmacy, I think Dr. Archana, our oral surgeon on the panel, she will, take care of this, the Beers list. In fact, I learned this from her because this was very important, because we have to judiciously plan what medications you have to give to your geriatric patient. So this particular thing is very important. Maybe this is today's homework for all of you all. The Beers criteria 2023. Ageist assumptions, there is a frown on every dentist's head, more or less, when you see an elderly patient walking in your clinic, because you have certain assumptions. And mind you, please do not go ahead with these assumptions. They are wrong. Patients, elderly, they cannot hear anything. Whatever I tell them, they just cannot hear. They cannot remember anything. They can't think for themselves. I just can't make sense to my patient. Or they are depressed and unproductive all the time. These are assumptions which are, absolutely, you have to get rid of them. That is the first step towards geriatric dentistry. And mind you, a person, a very debilitated person who is sitting in front of you may have been the chief of the National Chemical Laboratory in Pune. So this is real my experience. The chief principal of College of Engineering, Government College of Engineering, Pune. They have lived their life very, very successfully. But at this stage, they need a gentle attitude, gentle care. So please do not assume anything. One moment, let me just get back. Sorry for that.
Okay.
Can you see?
Yes, ma'am, we can see.
Okay, I'll just go full screen. One moment. Yeah. So all the branches in dentistry, here we are considering only clinical approach. So I have not included public health dentistry, but that is also somewhere here. And all the branches are there still preventive treatment and oral hygiene. I have highlighted why. Because preventive treatment and oral hygiene maintenance are imperative part of all the branches of dentistry, and they are very, very important for your elderly patient. 8 changes in the oral tissues. I'll not go much into the details because Dr. Asha, Dr. Ishita, they are already going to discuss about this. Oral health, major oral health issues, I'll just sum up. Even during their lectures, they are going to take this. So I have just narrated them. And these are the things which are very, very important when you face the geriatric patients' oral health issues. So deterioration of the teeth, hard tissues, and deterioration of the supporting structures. These are the two main points which we will be dealing with. Loss of multiple teeth causing aesthetic and functional problems. Poor health status of remaining teeth. We, remember your DMFT, DMFS index in community dentistry. Increased requirement of the dental treatment because the problems are multiple, the problems are complex. You require more dental treatment, multifold dental treatment. Degenerative changes in the oral and perioral tissues. So migration, what if there is loss of one tooth? What happens? Loss of one tooth can cause derangement of the teeth, not only the antagonist tooth, the adjacent teeth, and ultimately affect the patient's occlusion. So restoration of each tooth, rehabilitation of each tooth is important, and that is what you have to explain your patient as well. TMD and TMJ, very commonly seen in the patients which we treat, elderly patients which we treat. Some may be degenerative changes, some may be because of the faulty prosthesis the patient is wearing, some could be age-related. So let's take a look at this particular patient, okay? She reported to me not because she had any particular problem with the denture. Yes, chewing was uncomfortable, but her main problem was she had pain in her left TMJ. On examination, we found that there was severe maxillary and mandibular residual ridge resorption. The dentures were extremely ill-fitting, and mind you, she was from the affording class, but only, she was not aware that dentures are not there to stay. Dentures have to be changed every 3 to 5 years. Nobody told her that. She said once the dentures were comfortable that time, I just continued wearing my denture. Nobody told me about it. So faulty occlusal contacts, according to me, all these things which were existing, they ultimately were leading to her TMJ pain. We rehabilitated her, and mind you, this is Ekalavya learning, what I say, there is nothing is given in textbook. I would say not nothing. Everything is not given in the textbooks. I would say it that way. That is a more appropriate thing to say. That another thing which my physician friend said the other day, patients do not read the textbooks. Okay. So there are some, the things that whether TMJ and occlusion are related, they are not related. But I could find out that once I rehabilitated this lady's occlusion by giving her good dentures, proper jaw relation, and this is what she had to say. Thank you. So something which they call as evidence-based dentistry, this was the result that I got. Not the patient, not only the patient was satisfied, I was satisfied. The third aspect of the definition, that I could make her life, day-to-day life, comfortable. So edentulism, residual ridge resorption, this is the RRR that the prosthodontists are extremely scared of. It, reduces the facial height, facial appearance gets affected, and, because of all these things, you can, from the facial appearance changes from what are our nightmares as prosthodontists? Impaired chewing efficiency and performance. Thickness of the masseter muscle decreases in edentulous patients, thus decreasing the bite force. Masticatory efficiency gets affected. This could reduce the desire to bite, to chew, to swallow, and this could lead to soft food choices, which are wrong food choices, full of carbohydrates. One patient just told me, I'm losing weight. I said, why? What happened? The patient said, well, I take so much time to eat, chew my food, and, swallowing is little difficult. There is dryness of my mouth. I have lost interest in eating. See, this is what happens. And imagine a diabetic patient whose masticatory efficiency is extremely poor. That patient automatically chooses soft food choices like soft rice, soft upma, shira, which is, very detrimental to the health, because too much of carbs will have negative impact on the diet and food selection, which will lead to increase in the blood sugar levels. Even oral dyskinesia, the patients who are edentulous for a long time, they have these abnormal, involuntary, patterned or stereotyped, purposeless orofacial movements. They find it very embarrassing in public. So that is one reason, besides chewing, the well-being, the social, mental well-being of the temporomandibular joint and the overall well-being, extremely important. Hence, the rehabilitation is important for such patients. So this was one patient who came to me. He complained from a very, affording strata, I would say a higher strata of the society, a social worker himself. I taught him certain exercises. Let's call it oral physiotherapy. When you want to build your muscles, what do? You go to the gym, right? So instead, here in this particular scenario, the oral muscles, the facial muscles are sagging. The patient has this sunken look. So to improve that, we can suggest certain exercise to the patient after you give them the new dentures. Just let's take a look at this. Santosh, release. That is the tough of your lips. Slowly. These are some simple exercises which you can teach your patients to increase the tonus of the oral musculature. Loss of teeth, many patients are referred to me by the gastroenterologist or the physician in the hospital because they have irritable bowel syndrome. They have problem with digestion. So the patient per se does not come to me, but the gastroenterologist tells the patient, please go and see the dentist because your problem of your GI system are mainly because you're not able to chew your food properly. So impaired masticatory efficiency and performance, all the factors, again, the same thing. So this patient came to me complaining of flatulence, irregular bowel movements, indigestion all the time, ill-fitting dentures, existing dentures. Again, mind you, same thing, old, worn-out dentures. Okay, patient was from affording class. Simply, she didn't know. that she's supposed to go for a recall. She's supposed to change her dentures periodically. What I did for her, simple thing, nothing fancy, conventional complete denture, taking some special precautions. And let's see what she has to say. Sorry. So I think I'm having some internet issues. Dr. Bangar, you can hear and see the presentation properly?
The videos are a little bit hanging. Otherwise, the
Okay.
presentation is good. It's going
Fine.
smoothly.
If there is any issue, please point out, sir. We can skip videos because sometimes videos cause an issue. So we can
Yes,
skip
sir.
videos, no problem.
Yes,
You
sir.
just
Okay.
let me know. I will stop the video.
Sure.
So let's come to this. You have opened your clinic, you are in your clinic, and you have to treat a geriatric patient. These are some must-do things which I'm enlisting now. Please remember and start practicing them. A thorough medical, social, and dental history of the patient. Very, very important. Never start your treatment at the first consultation. Always take a thorough history with the help of patient and the accompanying person. A golden rule. Set these standards today. Tell the patient gently that always some relative, some friend, some family caregiver, somebody has to accompany the patient, and it has got a lot of importance. I'll explain you why. If there is a medical emergency, if there is a problem, this has happened with me, and that's why I learned my lesson. Twice or thrice it so happened that the patient just collapsed in the chair. And out of those 3 times, 2 times, there was nobody with the patient. So I learned my lesson because I could not contact the relatives. I could not do anything. I just had to rush the patient to the hospital. Once the patient was fortunately in the Nanath hospital, so we could provide care, revive the patient, everything was fine. But imagine if things would go wrong and if there is nobody accompanying the patient, imagine your plight. I have faced it. I don't want anybody else to face it. Contacts patient's physician. I have already said this when I talked about polypharmacy. Talk to the physician about known allergies and ongoing treatments, if any. Sometimes when you ask the patient, are you having any problems? The patient says, no, I'm not having any problem. Dr. Varsha Jaju, can you please silent your laptop, please? Yeah, thank you, ma'am. So contact the physician for ongoing treatment. Why it is important? Patient will not give you history. Are you okay? Yes, I'm okay. But the patient will not say that my blood sugar is okay because I'm taking oral antidiabetics, or my blood pressure is fine because I'm having some antihypertensives. So digging into the history, taking help of the caregiver as well as the physician, extremely important. Blood tests or any other x-rays, OPGs, whatever you want from the patient may fetch some age-old reports. No. Tell the patient that you want recent reports and define what is recent, done within last 2 months. Check all the ongoing medicines, prescriptions. Tell the patient to get the entire file always. Go through the file. If you have any problems to understand, again, ask the patient's physician. So you should have physician's contact number handy to avoid polypharmacy and drug interaction effectively. Take an informed consent. This is very, very, very important. That too in a language comprehended by the patient and relative. Don't flash a paper in front of the patient written in English when the patient understands only Marathi. Okay? So you have to have an informed consent wherein, if not the patient, at least the caregiver understands what's written in the form. Preferably, I would say in our country, we should have forms in English, Hindi, as well as in the regional language. So have forms in all 3 languages, whichever the patient and the relative prefers. The consent has to be duly signed. That is very important. or the thumb impression of the patient in case the patient cannot read and write. And or the patient could be debilitated also. And the patient in that case has to be explained everything by the caregiver. When the patient says yes, then there has to be a counter signature by the primary caregiver. Remember, this is extremely important, not only in your private practice, but also in the hospital practice. Medico-legally, extremely important. Talk to the patient and primary caregiver. As I said, first consultation, only consultation. First visit, only talking to the patient, and more important, listening to the patient. Listen to the chief orodental problems as well as any other problems or ailment the patient has. Make a note of it. Insist on having a responsible accompanying person. When I say a sentence repeatedly, please mind that this is extremely important and this is missed. So I'm reminding you again and again. Primary caregiver, close relative or family friend for every appointment. It is necessary. Why for the first appointment somebody came? Why do I need anybody? I can come on my own. Or, nobody has time for me. There are services, mind you, in city of Pune now that some people, some organization can accompany the patient. And you give a free hand. You tell the patient any relative will do, any neighbor will do. Some responsible adult has to be there. Okay. And when you insist, at least I insist that, uncle or auntie, unless somebody accompany you, I will not be able to do your treatment. And when you are gentle yet firm on it, they will listen to you. It's extremely important in case of any dental or medical emergency. Not only that, it makes the conversation easy and sometimes helps you to get the necessary information. Just find out if there is any underlying psychological problem. You are not a psychiatrist or psychologist, but you can notice changes. You are a clinician. So depression, delirium, and dementia, they can be noted during consultation, conversation with the patient, or, generally whatever inputs are given by the accompanying person. Identify the altered behavior. Please learn to identify what does not seem to be normal. You don't have to know what it is, but you have to identify that this is not normal. And clinical changes in physical, physiological, or psychological status of the patient have to be noted. And sometimes, during consultation, history taking, general and oral examination, if you come across this, then gently tell the patient and caregiver to see the concerned psychologist or psychiatrist or counselor. Loneliness and lack of attention, this is curse of the elderly generation that they are facing. Okay, so this could lead the patient to exaggerated symptoms. The denture is hurting, denture is hurting, denture is hurting. You take all the care. There is no ulceration in the mouth. There is no problem. You have ruled out all the occlusal contacts are bilateral and simultaneous. There is no problem. Still the patient keeps coming. Then start again probing, digging deep. Okay, if there are some non-existing causes and repetitive complaints, be gentle and try and find out what is happening. Sometimes they just want to talk to you. Sometimes they just want somebody to listen to them. They come with a problem, some minor issue, and then they tell you some family problem or some problem which is, causing them some mental unrest or something like that. You become not only their dentist, but you also are a doctor to them. So they come and talk to you. Try and identify the underlying psychological or emotional issue if there is anything. Speak to them about it gently but yet firmly. Make them aware if there is no dental problem, tell them about that. And in case necessary, tell them or insist at times to go to psychological counseling or psychiatric opinion. Here again, the role of accompanying person is very important. Be sympathetic and listen to the patient. The patient has so many things to say. Don't miss out on anything. Be patient. If you take around half an hour, I'm saying average per adult patient, normal adult patient, you will require 1 hour, 45 minutes to 1 hour for elderly. If you have that kind of time, if you have that kind of patience, only then you can practice geriatric dentistry. Make sure that the patient has grasped your question. Repeat the question if important and make sure that you're audible. Sometimes there is a bit of hearing deficiency. Make an eye contact to the patient and then speak to the patient. See that, if the patient cannot hear properly, at least the lip reading is proper and patient is able to comprehend. In case of hearing deficiency, you can have one thing that you can write down clearly, or the generation next, you people can use a largest font size and type out. You can take a printout and hand it over to the patient and the relative. So that would solve the problem. Ask the problem to write down all the complaints. Tell the patient, make it a habit to make a notebook. So many of my patients carry cute little diaries or cute little notebooks in which they put the date and write down the problems. When they come next, I have all the problems in front of me, even the smallest details, so that I can tackle and do an effective troubleshooting for them. It makes the identification of the problems very easy and troubleshooting easy. Schedule the geriatric patients during morning session, not too early, but when they finish all their morning rituals, their breakfast, their medications, if any, they are stable, they are feeling fresh, call them that time. In my field, I would say, imagine something like final impression, jaw relation for the patient. The patient has to be fresh, the muscles have to be relaxed, and the patient has to be cooperative. The geriatric patients are mentally and physically fresh during the morning sessions. So avoid late evening appointments. And sometimes they feel low in the evening, which is called as the sundowning effect, lowering of the physical and mental energy levels. So be careful of that. Avoid long appointments as the muscle fatigue sets in early for geriatric patients. Don't push the patients. Auntie, for some more time. Uncle, please, it's just little bit. Let's finish it today. It's finishing it today for you, but for the patient, it could be extremely tiring. If long duration is unavoidable, suppose a patient is, not able to cooperate for jaw relation, or patient is tired, then plan a toilet break. Allow them to sit for a while, listen to the music, have a coffee or snack interval. So the patient is mentally relaxed again, and a relaxed patient, mentally comfortable patient becomes a cooperative patient. Okay. So if the patient feels tired, as I said, don't say just some more time. Don't push the patient. Dental operatory. For you all, I can take another lecture altogether because I have discussed these issues with interior decorators, architects, and my friends who are abroad who are already practicing geriatric dentistry. There has to be a different design for your dental operatory, but some points I would just say that it should be well lit. It has to be perfectly bright so that the patients can see everything clearly. They have no problem entering, walking, no dim lights in the operatory. The operatory has to be well ventilated and geriatric friendly interior design. As I said, it's a topic by itself, so we'll discuss it some other time. Make sure that the operatory pathways are clear with non-skid flooring, no marble, no polished tiles, okay? Use non-skid. Be gentle and smile often. Smiling often, being gentle and being patient reassures the geriatric patients. So be that kind of a doctor with whom they feel comfortable, with whom they feel, they can feel a friendly atmosphere around. And so goes for your staff also. Tell your helping staff, motivate them to be nice, and be polite, be sympathetic with your geriatric patients. A comfortable atmosphere, besides the interior design, a comfortable atmosphere always makes the treatment go easy. So, these again, I come to this slide, okay? And here I'm going to harp on prevention. Okay, Ishita will definitely talk to you about all the preventive aids, but simple things like brushing, flossing, mouthwash, and easier still for our Indian scenario, drinking water often and rinsing your mouth with simple water. Mouth rinsing, extremely important for your patients, and that the patients have good compliance with drinking water often and rinsing mouth, which I think is a very good way of prevention of oral diseases. So educate your patient and the accompanying person. So when the accompanying person learns something, he or she takes a message back to the family about the preventive dental care and existing treatment problems, promote good oral hygiene, motivate to practice oral hygiene maintenance, effective follow-up, and recall appointments. This is going to give you the ultimate success. Educate your patient when to come for help. Bad breath, loose teeth, stained teeth. You haven't had a dental cleaning. This happened in COVID times a lot. People came after 3 years, 4 years, 5 years for dental treatment or a simple checkup. Any kind of pain, any discomfort, any irritation, ulceration, and last but not least, for my field, loose dentures. Prosthodontic treatment for the geriatric patients, about the glorious treatments like implantology and all. Ishita will touch upon it. Dr. Paresh Gandhi, who is an eminent implantologist, he will speak about it. As a general prosthodontist, I would say keep it simple and keep it case based. There is no rule. Every case has different treatment needs. So keep it simple and keep it case based is my motto. So what to think when you plan treatment for geriatric patients? Inability of the patients to attend long and frequent appointments. We have talked about that. Low tolerance for pain or discomfort during treatment. Residual ridge resorption, which again, as I have mentioned before, short dental arches. Attrition, abrasion, erosion, brittleness. Dr. Asha is going to touch this in greater details. And last but not the least, implants are possible for a patient, maybe, but the patient does not have that kind of financial support. The patient cannot afford. So financial constraints when the patient takes the dental treatment. Conventional complete dentures are already always there. They will never ever go out of fashion, mind you. So keep your base intact. Our base is based on complete dentures, removable partial dentures, crowns, bridge. This will never go out of fashion. So as I said, when I say case based, wherever it is important, wherever it is possible, complete dentures work wonders. So this particular concern of the same patient, Mr. Santosh, whom I showed the demonstration of oral physiotherapy, he had this concern of sagging facial muscles and a toothless look. Because he is a social worker and from a prominent strata of the society, he also made dentures 15 years ago. Nobody told him, and he never went to the dentist to make the dentures again. Treatment, simple, conventional, complete dentures. And that makes all the difference. And he's back to his happy social life. He's back to his active role in the Rotary Club. And he is a happy person simply with conventional complete dentures. This particular patients, I call myself queen of gag reflex because there are so many patients referred to me from outside who suffer from gag reflex. She had fulminating periodontal problems. Ishita will be able to touch upon that better. And suddenly she had, mobility in some teeth, partial edentulism, and she was also a bank officer. And, suddenly the change was brought about. She became partially edentulous, and that was a mental stigma. She was emotionally very, very upset. What I did for her, I restored her smile immediately. I gave her simple, immediate partial dentures. So, Dr. Bangar, if the video is not playing, please let me know.
Yes, ma'am. Yeah, the voice is not clear, ma'am. Yeah.
I will skip this video because I think I'm
Yes,
also
ma'am.
getting the sign that the network connection is unstable. So this
Okay,
was a
ma'am.
patient, again, as I said, about fall. The patient went abroad to meet his son, and suddenly at night he got up to go to the loo. This is another thing. They get up with a jerk from the bed. And because of orthostatic hypotension, they suddenly collapse and he had a fall on the face. To date, he tells me, doctor, I don't know how I had this fall. But for him also, as I said, immediate partial denture for aesthetics and phonetics because he wanted to look good. He came back to India and he immediately reported it himself to our hospital. You will see that I have put cotton plugs. This is just for my prosthodontic colleagues. They would like to know that there were so many spaces. Just look at his periodontal problems. Just look at the state of the teeth. So impression was impossible. When we poured the impressions, the models were breaking. So simple thing, simple clinical tip. I plugged in cotton over here and then I made my impressions. And this is something which we got. Patient was rehabilitated. He was a happy person with simple, flexible, removable partial dentures that were their immediate dentures. A happy person.
Smita, 5 minutes, sir.
Yes. I think I am about to finish. The claspless comfort for the elderly, the flexible partial dentures, but you need to know that in each and every case, you cannot use flexible dentures. There are limitations. Still, cast partial dentures are the best. This, we could say that it's a quick fix, but in some patients, as I said, for immediate partial dentures, it works for mentally and physically rehabilitating the patients. Okay, this was a case of oroenteral fistula. That patient came to me. She was on dialysis. Weekly, she had to go for dialysis. So she could not undergo any complex treatment. A simple, flexible denture for her, taking care of her oroenteral fistula. Okay, that helped her. So this is the patient. She could, she used to come to me for treatment and then she used to go for her dialysis. I just salute to such warriors. Cast partial dentures, always, as I said, my favorite and the best. Some unusual cases like palatal obturators, the cancer rehabilitation patients, simple palatal obturator made with simple, humble acrylic polymethyl methacrylate also gives a lot of daily comfort, day-to-day comfort in affordable prices to the patients. Mucormycosis. There was flood of such patients after COVID in our OPD in Dinanath Mangeshkar Hospital. What do we do? But at least to keep the patient, make them survive, we had to give them simple prosthesis, at least to give them liquid diet, at least to, make their life possible with nourishment, with nutrition, whatever they could take. So again, a simple prosthesis, this does not even have teeth, simple palatal obturator, post-mucormycosis surgery, which allowed the patient to survive. And then later on, we gave a permanent prosthesis to the patient. Guide plane prosthesis. This is, this is what happens, especially the oncosurgeons, they send the patients very late to us. And then the deviation sets in. So a simple guide plane prosthesis for this gentleman, I have given him as a, appliance, and the patient is religiously practicing it. As I said, that fixed prosthodontics, pay attention. Please respect the aging and compromised natural tooth structure and the supporting periodontium. That is my only thing. Again, be case-based. See what the condition of the adjacent tooth is. See whether implants can be placed. See whether the conditions are conducive to give either FPD or implants for this particular patient. Implant supported complete dentures, Paresh will talk more about it. And when planning, I had a discussion with Asha and Archana for our previous presentations. So take a thorough history of ongoing medications, systemic disorders. This particular case that I have put, this me and Dr. Paresh, we treated jointly. The patient came with fulminating oral candidiasis. And later on, when we probed for history, he had pancreatic problem, he had uncontrolled diabetes, he had cardiac problems. And that is what, led to this particular, scenario. And you have to be very, very careful whilst hastily entering into a treatment plan for such patients. First, understand the physical and physiologic limitations of the patient, and only then you proceed. After all, it's complete rehabilitation, not just the oral cavity, functional, social, and psychological well being. So let's work together for this cause, and let's, be of some use to the people who have worked for the society, worked for the family, and they are at the fag end of their life. So thank you very much. Thank you. I will stop sharing my screen now.
Thank you, Smita ma'am, for the wonderful lecture. It is always great pleasure to learn some tips from you from every lecture from your side. And today also you have highlighted so many things in your lecture, highlighting from the oral manifestation, some points to ponder like oral health, their socioeconomic status, medical status, and how to treat these patients in this functionally dependent elderly patient. So apart from that, one point that is I like it is, so the patient has one patient, but he has so many medications and ongoing medications, and to treat such patient is challenging in our dentistry. Second thing, we have to, as one of the authors said, we have to reach before reaching the mouth of the patient. We have to reach the mind of the patient, and to
So
reach
true.
it, yeah. And because the patient doesn't know to read the textbook, we have to read their mind and their face. So thank you so much, ma'am, for this wonderful lecture. Thank you so much once again.
Thank you.
Over to you, Dr. Shivani, for the further proceedings.
Thank you, ma'am, for your comprehensive guidance. Now I request the moderator to present the vote of appreciation to ma'am.
Ma'am, please kind accept the certificate of appreciation. Thank you so much, ma'am. Please accept this.
Uh,
Thank you so much joining and presenting the key lecture on this. So, ma'am, please accept the e-certificate. Thank you so much.
Now I request Dr. Bhagyashree to please invite the next guest speaker.
Can the screen be stopped now so that we can proceed?
Yes, ma'am. Yes, ma'am.
Thank you. Thank you.
I feel honored to introduce our next guest speaker, Dr. Archana Dusia ma'am. Archana ma'am is there on the screen.
I'm there now.
Yes. Again, welcome you, ma'am. I feel honored to introduce you, ma'am. She has done her UG and PG in the oral surgery from the Nair Dental College and Hospital. She has 29 years of experience in the various medical colleges. She started her career as a lecturer in the Department of Maxillofacial Surgery at Nair Hospital Dental College. She has 23 years of services at Department of Dentistry and Maxillofacial Surgery at LTM Medical College, San Hospital as the assistant professor and the associate professor. She is currently acting as an associate professor and the head of department in the Department of Dentistry and Maxillofacial Surgery at HBT Municipal Medical Colleges and RN Cooper General Hospital, Mumbai for having 6-year experience. She has different medal of award of appreciation. She is having Divanji Oral Surgery Medal for standing the first in the oral and surgery in the final BDS. She has Dr. Mehta Periodontology Medal for standing the first in the periodontology. She has been as a scientific chairperson at the many conferences and the deliberation. She has many publications in the national and the international journal. She is ex-EC member of Maharashtra State Chapter of Association of Oral and Maxillofacial Surgery. I request you, ma'am, to start your presentation.
Yeah, I'll just share my screen. Yeah. Can my screen be seen?
Yes, ma'am. Yes, ma'am. Please go on to the main point.
Yeah, 1 second.
Viewer mode.
Yeah. 1 second. 1 second. There's some
Yes, sir.
problem. Yeah, 1 second.
Dr. Archana, there is slide share below also.
Lower right
The
side.
right hand side below, there is slide share. Right side below of your screen.
Yes, ma'am.
Yes, Archana, we can see
Yes,
this. We can
we
see
can
the
see it.
presentation. Yeah.
Yeah,
Okay,
now
ma'am.
it's
Yes,
okay?
Yeah,
yes,
Yeah.
perfect.
ma'am.
Perfect,
Yeah,
perfect.
okay. At the outset, I would like to thank the Dean of your college, Dr. Kangane, I think, and Professor and HOD of Prosthetic Dentistry for giving me this opportunity, and also Smita Thavle for including us in her dream project. So, as all of you know, geriatric dentistry is not a one man's job. It has to be a multi speciality approach involving various specialities. So, what is the role of an oral and maxillofacial surgeon in geriatric dentistry? Well, we as oral surgeons may be called in to support the other specialists in giving close to ideal conditions by means of very many surgical procedures for satisfactory prosthetic rehabilitation. Now, some of the most common types of surgical procedures which we may be called in for may include extraction of grossly mutilated teeth, teeth with root caries, mobile teeth with severe periodontitis, transalveolar extractions of submerged root pieces, pre-prosthetic surgery involving both hard and soft tissues, management of some TMJ disorders in older adults, especially the degenerative ones and the hypermobility disorders, management of hyposalivation or xerostomia, and also management of geriatric trauma. Now, before jumping to the procedures, I would like to stress on the importance of preoperative evaluation and workup for geriatric patients. It is absolutely required as old age comes with comorbidities and polypharmacy. So, if your pre-op evaluation is strong, you are less likely to encounter major problems as you will be prepared to handle them. So, the preoperative assessment and workup are basically to minimize the perioperative morbidity and mortality to the best possible intent. Our third BDS medicine surgery classes should be recalled, and detailed medical history, physical examination, and necessary lab investigation should be done. Now, detailed history should include any previous medical history, any surgical procedures which the patient has undertaken before, any personal or social history, the history of their polypharmacies, the allergies. So we see that the patient's comorbidities may result in a significant physiological decompensation due to myriad of factors such as stress of surgical procedures and potential interactions between the regular medications which the patient is on and the drugs which you are going to give as part of the procedure. So the surgeon should be cognizant of what could possibly go wrong and how to remedy it. Now, we all know that old age, there will be a decrease in functions of almost all the organ systems. There will be increase in the incidence of comorbidities. Increase in life expectancy may cause more and more elderly patients to visit your clinics. So knowledge of physiology and pathophysiology is never too harmful. Now, sometimes you may have patients who have a decrease in cardiopulmonary reserve, or there may be increased risk of cognitive dysfunction, cases of dementia, delirium, depression may be there, and all these may get exacerbated in acute perioperative phase. So it is very important that you do not operate on a stranger. Plan your anesthesia, plan your surgery and postoperative pain management. Never hurry up to any treatment plan. There is absolutely no substitute for a properly performed detailed history and physical examination. And professional opinions of consultants of all other specialties should be taken as and when required. Now, coming to vital signs, it is very important to monitor the vital signs preoperatively, especially more so in geriatric patients. So you must monitor BP, pulse, SpO2 before doing any procedure. The baseline, it will give the pre-op monitoring will give you a baseline reading, and it will help you in deciding whether to go ahead with the procedure or to defer the procedure. Now, for you, it may be a small procedure or a routine procedure, but remember that routine procedure combined with old age and comorbidities becomes a high risk case. Also, the basic investigation should be done in all surgical cases. Not only all surgical cases, even minimally invasive procedures like root canal or scaling. So you must do at least CBC, BTCT, PT-INR, fasting and postprandial sugar in all the patients. Now, once the medical history which you have elicited will help you in risk assessment of the patient. So if there is a patient with cardiovascular disease, you will know that there is a risk in elective dental treatment. You will not give vasoconstrictors to somebody who is on digoxin, as the combination of digoxin and local anesthetic agent with vasoconstrictor can cause arrhythmias. Now, some patient comes to you immediately after a myocardial infarction. Then there is these patients are at high risk of reinfarction and heart failure. So you will not do anything and defer the procedure. Patients, sometimes they are on antiplatelets, anti-anginals, calcium channel blockers, and these interact with the vasoconstrictors, and which can be very lethal to the patient. Now, some cases where there is a history of chronic bronchitis or asthma, you may have to avoid the medicines or injectables that depress the respiratory system or irritate the airway. Then you may have to avoid the rubber dam, as it gives a choking feeling to the patient, and patient may prefer supine chair position. Similarly, there are patients who will come with osteoarthritis or rheumatoid arthritis, and they are on NSAIDs, corticosteroids, immunosuppressants, etc. So these patients may have a bleeding tendency. They may be more predisposed to infection. The chair position can be a cause for physical discomfort. And some patients who have joint prosthesis, they may be at risk of infection during dental care. So you may have to give them prophylactic antibiotics. Similarly, in cases which are cases of diabetes, mellitus, especially the ones who are insulin, they may be more prone to infection, and they may go into hypoglycemia if the meals are skipped. So optimal treatment planning for older adults requires an understanding of the overall health of the patient and the repercussions it is going to have on the outcome of your treatment and the patient's oral health. Now, coming to anesthesia for older adults. Now, when you are deciding what anesthetic agent to use for a particular geriatric patient, you have to keep certain factors in mind, like whether the patient is allergic or no to the local anesthetic which you are going to give. The pharmacodynamics you have to understand in geriatric patients, because in geriatrics you may see delayed clearance, low metabolism, and you have to see to it that the local anesthetic agent does not interact with the other drugs which the patient is on. So you have to select the anesthetic drugs according to the patient's general condition and coexisting pathologies. So it is highly recommended that you use a local anesthetic agent without vasoconstrictor. But if it is absolutely necessary, then you must give only the optimal concentration, that is 1 in 2 lakhs of adrenaline. Now, in old patients, we see that the nerve axon function deteriorates, the nerve morphology changes, and the surrounding connective tissue disappears. So this leads to an increased sensitivity to the local anesthetics. So we need to give smaller doses in the geriatric patients. Also, so many of them will have cardiovascular disease comorbidity, and it makes them more susceptible to hypertensive crisis, congestive heart failure, angina, and arrhythmias. So in such cases where there is a pre-existing cardiac and cardiopulmonary disease, the maximum amount of epinephrine that you can give is 0.04 milligrams, and a relatively safe amount of the anesthetic agent which you can give is approximately 70% of the maximum dose given by the manufacturer. Now, coming to oral sedation in the elderly can be difficult because of difficulty in titration of an effective but safe dose. The most common agents used can be antihistamines or benzodiazepines. The benzodiazepines are preferred. They are safe and effective in medically compromised and cognitively challenged patients, but should be given in lower doses. The most common ones used can be lorazepam or triazolam, but triazolam has to be given with caution if there is a patient of glaucoma, a patient who is having depression, or he is on phenytoin. Now, when you are planning extractions in a geriatric patient, you must assess the quality and quantity of the hard and soft tissue. And if you want to give implants, then there needs to be adequate bone volume. Also, in old patients, there is an increased chance or a likelihood of osteoporosis. So when you do the extractions, the alveolar bone would have resorbed more to give a very atrophic alveolar ridge. The soft tissue quality also will be inferior, lacking keratinized gingiva. When planning the extractions, you also have to keep in mind certain anatomical structures so that you can have a safe surgical practice. So structures like inferior alveolar neurovascular bundle, the mental nerve, the maxillary sinus, and the floor of the nose. All these structures may come to lie more superficially as the alveolar bone resorbs. The mandible also, if you see in the elderly, it has decreased blood supply. The blood supply is much less from the inferior alveolar artery and more from the periosteum. So it is important that that you keep the periosteum as viable as possible and protect the periosteum. Now, sometimes the extractions may be complicated in geriatric patients because of attrition, brittleness of the teeth. The secondary dentin deposition in endodontically treated teeth makes the extraction complicated too. Then the elderly patients also have low bone density, hypercementosis, frail atrophic mucosa, and dry mouth, which also complicate the soft tissue healing and extraction procedure. You must always talk with the restorative dental surgeon so that only the appropriate teeth are removed. When you want to, when you're thinking about of giving a overdenture, then even the coronally unrestorable teeth may be of some use. And you must consider the patient's ability to withstand the planned surgical procedure always. Concomitant medical consultation should always be taken. If necessary, the procedure should be staged over multiple appointments. If transalveolar approach has to be used, then you try and keep the bone removal to minimal. You also have to consider the physical limitations and cognitive impairments, and also the mental health needs, as these patients are more susceptible to social isolation and loneliness. Now, there may be certain risks involved when you are doing tooth extraction for geriatric patients, and these could be risks of infection as they have low immunity due to overall health and age. There may be risk of bleeding because of certain comorbidities or the medications which they are on, like antiplatelets. There may be risk of complications from anesthesia. They may have longer healing period, especially in diabetics and the patients who are having osteoporosis. Then some patients who are taking radiation therapy for cancer, there may be a risk of osteoradionecrosis. So all the risks and complications should be explained to the patients before, so that they are mentally prepared and comfortable during the procedure. Even bite collapse can happen, when you extract multiple posterior teeth, and it will change the type of movement and muscle contractions required for chewing correctly. So this will indirectly affect the nutrition. So all this should be explained to the patient. Now, these are some of the common complications you may come across: fractured tuberosity, bleeding extraction sockets, especially when the patients are on antiplatelets. Then oroantral communications and oroantral fistula, because the sinus floor has dipped down due to alveolar resorption. Dry socket. Now, coming to pre-prosthetic surgery. Now, these are procedures which are used to enhance denture-bearing areas, and they include a variety of soft and hard tissue procedures. So what we are supposed to do is we are supposed to give ideal bone to the prosthetic dentist for best denture support. Now, what is best denture support? It should not have any pathologies. There should be adequate palatal vault. There should be no soft or bony protuberances or undercuts. There should be adequate keratinized gingiva, adequate vestibular depth, adequate bony support and soft tissue covering for implant placement. So our goal should be to give satisfying aesthetics and function, and creation of a broad ridge for denture and implants. Now, many procedures come under the ambit of pre-prosthetic surgery, and these may include soft tissue operations, which are enlisted here. Then you have hard tissue surgeries like alveoloplasty, tori removal, maxillary tuberosity reduction, etc. And the ridge augmentation procedures and ridge extension procedures, or in other words, the vestibuloplasties. Now, coming to the ridge correction procedures, it's nothing but alveoloplasty, which is reshaping of the alveolar bone to remove sharp edges. And the shape of the ridges should be such that there is sufficient width and height to be able to distribute the forces properly. Now, this intercortical alveoloplasty is a variant of alveoloplasty, which is done when you are thinking of giving immediate denture, especially in the anterior region, and when the alveolar process is prominent. So this is alveoloplasty after multiple teeth extraction. This is Dean's alveoloplasty diagrammatic representation. Dean's alveoloplasty is also intercortical alveoloplasty. And this is single tooth alveoloplasty. Then buccal exhaustosis. So sometimes you may see cases with buccal exhaustosis. They are seen more in the maxilla. So they will come in the way of denture construction. So you have to excise and trim the buccal exhaustosis. Sometimes you may be called in to recontour the edentulous alveolar ridge. You can see such bony protuberances may be there, and they need to be taken care of. You may find genial tubercle which becomes prominent with alveolar bone resorption, and the attached genioglossus muscle also becomes prominent, and it causes displacement of the denture. So you need to trim it. Sometimes the mylohyoid ridge also may become sharp, and the denture flanges are impinging on it and causing patient pain and discomfort. So if you are going to place implants, then there is no need for mylohyoid ridge reduction. But if you are considering a denture, then you have to reduce the mylohyoid ridge, sharp ridge. Now, sometimes there may be a maxillary tuberosity which is enlarged in size and it engorges into the intermaxillary space and interferes with denture placement. So you have to create space for the placement of the denture. So you need to remove it and trim it. Now, this is how the bulbous tuberosity is removed. Now, sometimes you may have patients with tori. Now, in edentulous patients, the presence of a palatal tori will preclude the smooth placement of denture. So the removal is required. This is the removal of the palatal tori. This is the removal of the mandibular lingual tori. Now, sometimes you also may see patients with reactive inflammatory papillary hyperplasia, which may be due to prolonged wearing of an ill-fitting denture in areas where the denture flange rests. So you have to excise and give a smooth ridge to the prosthodontist. Sometimes you may have to excise the excess tissue from a flabby ridge also. Then sometimes you may come across pathologies in geriatric patients like this giant fibrous epulis, which needs to be excised. Maxillary tuberosity, soft tissue may be in excess and you have to excise it. You may have inflammatory papillary hyperplasia of the palate due to chronic denture irritation and you have to take care of it too. Coming to frenectomies, now active and strong frenal attachments interfere with the placement of dentures and their relief is very much required. So this is the labial frenectomy. This is the lingual frenotomy. Now coming to ridge extension procedures, these are nothing but vestibuloplasties, where the vestibule is deepened by changing the soft tissue attachments. And for this, you need to have sufficient height of the alveolar bone. And this will help in accommodating large denture flanges and giving more stability and retention. Now, sometimes you may need to transposition the mental nerve also when the ridge is so severely resorbed that the mental foramen comes to lie very superficially. And when the patient wears a denture, it impinges on the mental nerve and patient gets severe pain. So you need to surgically relocate the mental nerve from the foramen. Now, ridge augmentation procedures, especially done in the atrophic maxilla, and the example of this could be sinus lift and grafting procedures. Now, coming to TMJ disorders in geriatric patients. Now, 1 in 3 elderly adults may be affected by TMDs, which is a painful condition, and the patient may come with pain, clicking, or crepitus. Now, mostly you will see a degenerative joint disorder. Mostly you will see a degenerative joint form of the disease. In majority, the symptoms are self-limiting. And after 5 to 8 years of initial diagnosis, the clinical symptoms will resolve and only 15% may progress to the severe form. Now, we all know that as one ages, the functional demands of the TMJ may exceed the repair and remodeling capacity of the joint, resulting in degeneration. So also you will see that there is a reduction in the muscle strength. The disc which absorbs shock will move out of the correct position. There may be extensive dental restorations like crowns, ill-fitting dentures, which may contribute towards the TM joint pain. Bruxism and habits like continuously chewing supari, tobacco may also contribute towards the TMDs. Now, patients who are having osteoarthritis and rheumatoid arthritis, now see osteoarthritis patients may have a loss of cartilage and there may be osteophyte formation giving rise to pain. And in rheumatoid arthritis cases, you may have inflammation of the joint resulting in destruction of the cartilage and eventually joint pain. So all these factors contribute towards the TMDs. The treatment mainly is conservative, which includes patient education, jaw exercises, thermal therapy, ice pack in acute cases, and later on heat pack, soft diet, anti-inflammatories and muscle relaxants, and parafunctional habits have to be corrected. Now, coming to hypermobility disorders, You may see these disorders in sometimes in geriatric patients in the form of dislocation and subluxation. And the etiology here could be trauma, the dental procedures which require the mouth to be opened wide for a long time, intubation procedures, the laryngoscopy procedures. Sometimes it could be spontaneous while laughing or yawning and vomiting. Sometimes there are some anatomical aberrations like small condyle or laxity of ligament and capsule, which may make them more prone to dislocation. Then patients who are having Parkinson's disease, muscle dystrophies and dystonias, also patients with edentulous posterior region, they may be more prone to dislocations. Now this you can see a bilateral TMJ dislocation. This is before reduction and this is after reduction. This is unilateral TMJ dislocation before reduction and after reduction. Now, how do you manage the acute dislocation? Everybody knows that we use the Hippocratic or the Nileton's method, or sometimes you can use the gag reflex. These are the most common methods which I use. This is Hippocratic or Nileton's method, where the thumb is placed intraorally on the occlusal surface and the other fingers are placed below the angle of the mandible, and the mandible is pushed downwards, backwards, and upwards. Now, gag reflex, what you do is you just probe the soft palate with a mouth mirror. This will create a gag reflex and relax the lateral pterygoid muscle through coordinated neuromuscular activities, which will reduce dislocation in a natural way. Now, sometimes they may have chronic recurrent dislocation. So here you will reduce the dislocation and give them intermaxillary fixation, chin straps or Barton's bandage and tell them to wear them for at least 1 month or so. And you may sometimes have to resort to minimally invasive procedures too, like injection of sclerosing agent for capsular fibrosis, prolotherapy where dextrose is injected, which stimulates the regeneration potential, and botulinum toxin injection type A, which will weaken the muscle. Now coming to xerostomia or salivary gland disorders. Now, salivary xerostomia or hyposalivation. This could be mainly because the patients are on tricyclic antidepressants, sedatives, and drugs for Parkinson's, chemotherapeutic agents. Now, these drugs, due to the anticholinergic and antiadrenergic effects, inhibit the production of saliva and its constituents and can affect adversely the transport of saliva from the acinar cells till the major excretory ducts and ultimately the mouth. Sometimes patients who are taking radiation therapy, especially those who are having cancers, the radiation can cause destruction of the serous producing cells. Also, some of the patients have Sjogren syndrome, in which you can see xerostomia. Now, the patients may come with root caries, dry depapillated tongue, pseudomembranous candidiasis, desiccated buccal mucosa, angular cheilitis, and denture stomatitis. Now, treatment strategies will include a combination of supplemental fluoride. You counsel them for oral hygiene maintenance, anti-karyogenic diet. You will give topical palliative agents for candidiasis and denture stomatitis, topical antifungal agents. Water is very important, as Dr. Smita also mentioned. You must tell the patient to regularly sip water at intervals throughout the day. It not only helps to moisten the oral cavity, it hydrates the mucosa and also clears the food debris from the teeth and mucosal surfaces. Another treatment which can be useful, especially at night, is the use of room humidifiers. Then there are so many commercially available oral rinses, mouthwashes, and gels, which can be prescribed to the patients. Now, then you can also use salivary substitutes or silagogues, chewing gums containing sorbitol or xylitol, cholinergic drugs like pilocarpine or cevimeline, then vitamin C tablets like Limc or Chu-C can be prescribed. Now, these are all the commercially available products in the form of mouth rinses, gels, which can be prescribed to the patients. Now, coming to geriatric trauma. as an oral surgeon attached to a public medical college and general hospital, we see a lot of trauma patients and a few maybe geriatric patients. And most of the time, we have seen that the etiology in them is either falls, RTAs, or assaults. Now, we know that in old patients, there is decrease in proprioception, there is decrease in their defensive reflexes, they have muscle weakness, they have tremors, they are on so many psychotropic drugs, they have systemic pathologies. All these make them more prone to accidents and falls. So, loss of teeth with decreased vascularity will lead to atrophy of the residual alveolar bone, which in turn decreases the strength of the mandible and creates the mandible more prone to fracture. So the decreased blood supply in the mandible along with the reduced bone volume can compromise bony healing in elderly patients. So when you are planning the treatment, certain factors have to be kept in mind. You have to think about the blood supply. So many times in old patients, you will see that the inferior artery is not found, or it is greatly reduced in size, and the blood supply of the mandible is more from the periosteum and less from the inferior alveolar artery. The position of the inferior alveolar neurovascular bundle, which may be more superficial. So you, if you are taking an intraoral approach, it may be hazardous to the bundle sometimes as compared to when you will take the extraoral approach. Also, the distance between the maxillary sinus floor and the alveolar ridge decreases in the old patients, and this coupled with the thin lateral wall of the maxillary sinus can produce a severely comminuted Leaford 1 type of a fracture. Now, mostly the mandible is involved in geriatric patients. Now, when you have to think about what treatment to give, whether it should be conservative or it should be radical, generally, we would prefer conservative treatment based on mainly on the issues inherent to surgical risk. Close reduction techniques are best accomplished with a mandible that is at least 30 millimeters in height. If it is less than 10 millimeter in height, it is difficult to control the atrophic segments. So this can be accomplished by using a pre-existing denture, or you can make a gunning splint and they are wired to the mandible with circummandibular wiring. So the advantage of the close reduction is that there is no surgical incision and the periosteal blood supply is kept intact. Also, if there is a medical contraindication or the patient is unfit for GA, then you can go ahead with the close reductions. The disadvantages could be that their nutrition suffers and their polypharmacy also suffers as they are not able to take the medicines properly. Now, open
Dr. Archana,
yeah,
sorry
I'm
to
just
interrupt.
finishing.
Yeah,
Huh?
yeah. Thank you.
Open
5 minutes more you
reduction.
have. No problem.
Open reduction techniques have to be considered when there are continuity defects and unstable fracture segments. The advantage of this will be that the patient returns immediately to function and nutrition, but the disadvantage could be that they pose a greater challenge to the patient's cardiac, pulmonary, and wound healing abilities. Also, prosthodontic treatment may be difficult because in the presence of plates and screws, the denture border adaptation may be difficult, or the placement of implant may be difficult. This is how the circummandibular wiring is done. This is a picture which shows close reduction in a bilateral condylar fracture using splints with the pipe blocks. And this is a fracture mandible in a geriatric atrophic semi-edentulous mandible, where one plate was put as the height of the mandible was not much, and IMF screws were used for intermaxillary fixation. Now, sometimes we may come across pathologies in geriatric patients. So this is a case where it was a huge dentigerous radicular cyst in the anterior maxilla, which was enucleated out. Now, a little bit about osteoradionecrosis. Some of our patients may be cancer patients who are on high doses of radiation, and we all know that radiation reduces the vascularity and reparative power of the bone. So any subsequent trauma in the form of tooth extraction or infection leads to osteomyelitis, sequestrum formation, and the patients may come with pain, trismus, swelling, orocutaneous fistulae. So this is how the osteoradionecrosis will look like clinically, and this is how it will look in the radiographs. Now, prevention is the choice. Prior to radiotherapy, you will extract all the bad periodontally compromised teeth which are in the line of radiation. During the therapy, you will advise mouth rinses, advise them to maintain their oral hygiene well, prescribe anti-karyogenic diet, and post-radiation, tell them to avoid denture uses and prescribe salivary substitutes to them. Extractions post radiotherapy, no extraction should be done up to 6 months post radiotherapy. Now, sometimes patients who are on clodronate or alendronate, which are bisphosphonates, and they are prescribed in cases of osteoporosis and multiple myeloma, these patients may develop medication-induced osteonecrosis of the jaw, which is very, very rare. So, if they are on bisphosphonate therapy for less than 2 years, not a problem. But if the bisphosphonate therapy is going on for more than 2 years, then they are more likely to develop osteonecrosis. And if you want to do any surgical procedure in such patients, the bisphosphonate-free period of at least 2 to 3 months is required. So I would conclude by saying that we are not stressing on the techniques of oral surgery, but we have to pay attention to certain factors related to age in geriatrics, like changes in the bone, blood vessels, vascularities, comorbidities, drugs that interact with LA, factors related to mental health, which can affect the outcome of your procedures. So we do not have to master the techniques, that we will do it anyways, but master empathy, communication skills, knowledge about age-related changes, physiology and pathophysiology, and then in the true sense, we can call ourselves geriatric dentists. Thank you.
Thank you so much, Archana ma'am, for the wonderful presentation, highlighting the points of the pre-prosthetic surgery, TMD management, gerostomy management, geriatric and osteonecrosis management. Thank you once again. And we have to not to reach only the mental condition, but not the physical condition, but we have to reach the mental condition of the patient. And what is the key point from your lecture is the safe surgical practice.
And
So,
pre-operative assessment and workup. That is the most important thing.
yes.
If you have taken the history properly, if you have worked up the patient properly, you are less likely to have problems.
Yes, ma'am. And starting from the anesthesia to the elective
Yeah.
surgical procedure, what precaution that we have to take care.
Yeah.
So, thank you so much, ma'am. Once again, over to you, Doctor, for the next proceeding.
Yes, sir.
Thank you, ma'am.
Thank you, Dr. Archana ma'am.
Thank you, ma'am.
Thank you for calling. Yeah.
Hello. Yes. Thank you, ma'am. Thanks for the wonderful presentation. It was very informative one. As we all know that geriatric patients are very sensitive one. There is a popular saying, a man growing old becomes a child again. Thus, it becomes very important for all of us to know how to manage these geriatric patients. So these patients require a very sensitive care. So it was a very informative session. I once again thanks ma'am for this wonderful presentation. Thank you, ma'am. Kindly I accept the certificate, ma'am.
Yeah. Thank you so much. Thank you.
Thank you, ma'am.
I request.
Yeah.
Thank you, Sriraj Badal sir, for being as a moderator for this wonderful session. Over to you, Dr. Shivani. Our next speaker is Dr. Asha Nerde ma'am.
Asha Norde.
Asha Nerde ma'am is a conservative dentist and endodontist. She has been in clinical practice since 1995. She has graduated from Nair Dental College and Hospital in the year 1990 and has completed her post-graduation from KLE Dental Science Institute of Dental Sciences, Belgaum in the year 1994. She has acquired training in advanced endodontics and use of dental microscope for the same internationally under reputed endodontists. She is a consultant at the Center for Advanced Dentistry at Bridge Candy Hospital Trust, Mumbai. As an endodontist since the year 2009, she was the recipient of the Special Jury Award for the Outstanding Clinician by FAMDent Excellency in Dentistry Awards in the year 2022. Her focus is on treatment, retreatment, and rehabilitation of the decayed and worn dentition in young and geriatric patients by performing endodontic, restorative, and preventive therapy efficiently and rapidly with predictable results. She has been lecturing extensively to create awareness on oral health needs in geriatric population. The moderator for this session is Dr. Ramchandra Kabir. Now I request ma'am to please start the presentation.
Just wanted to check with the organizers and Ishita both. Actually, Ishita was to go after Dr. Archana's presentation. Dr. Ishita, are you okay or you have any time constraints?
No, ma'am, it's okay. If it's going to finish in another half an hour's time, it's all right.
Yeah, because Dr. Ishita at present is at Nagpur with some commitments. So I was little concerned whether she has to go somewhere and, Ishita, please feel free. It's amongst
Sure, ma'am.
ourselves, we can decide.
Sure, ma'am.
Ishita, I have
I'm-
no problem. You can go